Welcome everyone. Delighted to welcome you to this morning's session as part of the Data Talks programme. It's been an absolutely fantastic programme that the team brought together, and I'm sure that this morning's session is going to be equally stimulating. My name is Sian Evans. I am a consultant in public health with the Office for Health Improvement and Disparities, where I lead the local knowledge and intelligence service for the East of England, and really delighted to be asked to chair this morning's session on the transformative power of linked data. We've got three excellent speakers, and I know it's going to be a really stimulating session this morning. Colin, if you could move on to the next slide. So just before we start, a bit of housekeeping, and for those of you who've joined any of the other data talks, I suspect that this will be very similar, familiar to you. So for anyone who's not a presenter will have their microphone muted and their camera off. This is just to allow everyone to be able to focus on the presenters. We have a Q&A session, so if you do want to ask a question, please do use that, post a question in the Q&A in the chat. We've got three presenters, and we'll be keeping all of the questions to the end of the session, but please do, as you go along, post those questions, and we'll do our best to keep a bit of time at the end of the session to pick up one or two questions. And finally, the meeting is being recorded, and so it will be available on the YouTube channel at the end of the conference. So if we could move on to the next slide. Thank you very much. So I've just got one slide just to set the scene before we go into the main bulk of the session. And I've taken some extracts from an article that was written by the Chief Medical Officer, Professor Chris Whitty, published back in September of last year. And I've put the link to the article, and I would urge people to read the full text. It's not too long. It was just too long to put on the one slide. But in that article, Professor Whitty talks about the importance of data to the NHS, and really how it underpins the provision of healthcare. And he talks about how all of us who use the NHS contribute to the data, and all of us who use it benefit from the data being used effectively and safely. And Professor Whitty talks about three ways in which the NHS can use data to improve health. Firstly, in terms of individual patient care. So whenever we go to seek treatment, we'd like the clinician treating us to have all of the information that they need readily to hand. Secondly, we use it to improve the effectiveness of the services that we provide. So understanding whether we're providing the services in the best possible way to ensure the best outcomes, best experience for patients and the best outcomes. And thirdly, to support research so that we're driving the development of new knowledge and evidence to understand how better to provide services and improve care. But at the moment, one of the challenges that we face is the NHS have multiple data systems that don't necessarily talk to each other. And that means that so that when we do thinking about patient care, that means necessarily that not all clinicians have the information to hand when we go and seek treatment, and patients end up having to repeat the same information over and over again. And when we think about delivery of services, we're aiming to be able to deliver integrated, seamless care. And in order to do that, we need to have integrated, seamless data. The good news is that there's a lot happening across the health service to address this and try and join up those data systems. And this morning, we're going to hear about three really exciting examples from within the Essex system about what the action that's been taken to link that data and how it's being used to drive improvements in the services and better health outcomes for patients. So at that point, I'm going to suggest that we move on to our first presenter, and I'll hand over to Stephen. I'll let you introduce yourself, Stephen.
Thank you, Sian. Good morning, everyone. As Sian was saying, we're going to talk. So there's three of us speaking this morning. So there's myself, Alex, who's from the north of Essex. I'm from mid and south, and Carl will be covering off West Essex. We're all work for various ICSs, Integrated Care Systems. We'll talk a little bit about those in a second as well. But each of us will talk about how we've approached this particular area of getting more insight out of data. It's not only linking the data together, but it's how do you get more insight out of that data as you bring it together. So as I say, my name is Steve Gallagher. I look after data and business intelligence in Mid and South Essex, ICS. On ICS has been around for about 3 years now. It stands for Integrated Care Systems. These really were starting bringing together partnerships really of health providers, local organisations, could be charities, could be councils, etc., but trying to bring us together so we can start to give more insight. But more importantly, it's about improving what's called population health. I'll talk a little bit about that in a second as well. But it's also to allow and decrease inequalities and address that, but at the same time as well, try and produce more productivity, really get more value out of the money that's been invested. So that's what ICSs were set up for. If I go to the next slide, please, whoever's driving the slides, thank you. Okay, so in this first slide here, we go back, we wind the clock back about 3 years. So in Mid and South Essex, but across England, ICSs were being set up. And as Sian said in our introduction, one of the issues is it's great to have a strategy. It's great to want to deliver more for our residents or for our patients, but most of the data tended to sit in disparate systems, unlinked systems. And part of our task has been not only to go and find that data, but to bring it together in a cohesive way to get insight from it and get over some of those other boundaries that are there around information governance, privacy of data, etc. So really, this is where we sort of started out, and it's important if we're going to get this sort of insights that we actually have to address all of these. As we said before, a lot of the data wasn't linked together. It really wasn't. So we had to set that task, first of all, to start to bring that data together, but put it onto a platform where it can be analysed and reported from. So Mid and South Essex, what we did to address this is we actually set up a system that is known as Athena. We started on this project about 18 months ago. We're quite a way into it now. But Athena, as you'll see in a second as I start to talk through it, has taken a lot of what were potential problems and have hopefully resolved those, but allow us now to get that insight that we're after, to drive that change, to get the insight and make that difference from there. That's really where Athena evolved from and started from. So if we go to the next slide, please. I'm not going to go into too much detail around Athena, but it's very much important to sort of say that this isn't just static, that we haven't just built something and left it. We're starting to build new components into Athena all the time. At the same time, we're trying to resolve a number of, what we call them, issues that were out there, where we had, for example, all different types of software, different vendors, etc. What we've done is we've consolidated down on Athena onto a single Microsoft platform. So we use just purely Microsoft products. So it leads to one, standardization, allows us to make full use of the platform. But again, it has a very sort of rich database. It's cloud-based Azure. We can use the Power BI tools at the front end, but equally our studio, etc., at the back to do the analytics as well. So single technology was the first thing that we did. The second thing we did was to get security right, so access to Athena around role-based access. So who can log on, what can they see when they log on, etc. We took advantage of some technology that's been around for a while. NHS England use it quite a lot. It's called Okta. So we use Okta, which controls, as I say, who can access, when they can access, etc., and what they can see once they get on there. So we're using Okta. We spoke about this linkage, this data sharing as well, and we made sure from day one that what's called information governance was addressed very, very early on. So each time we find a new data source, we make sure we get those data sharing agreements in place very, very quickly, and what's called sub-licensing, where we can actually start to share across various organisations as well. That's quite key to get those in place. At the bottom of that particular slide, we've got a lot of data on there. There's a number there. That number goes up all the time, but we have an awful lot of data stored on there, and I'll talk a bit more about that in a second, the different types of data. But it is bringing that disparate data sets together. The magic really is how you link it to get insight from it. So I'll talk a bit more about that. I'll talk a little bit more about advanced analytics. It's more than just dashboards. This is more than just Power BI. We've created an environment, a sandbox in effect, that allows analysts to go in and start to query the data that's underneath, the information about our residents and our patients, etc., so we can get additional insights out of that. So again, using tools like our Studio, if you're familiar with that, we can point that at that data set to get more insight. And I'll talk about 2 examples where we've done that. And I'll talk a little bit more later about those additional data sources. We're not standing still here. We're constantly looking at new data sources where there's a benefit to our residents, where there's a benefit to our patients. We're looking at other data sources. If we can improve that richness, that view of our resident, that's what we're looking to do. So we go forward a slide, please. Thanks. Don't plan to drain this particular screen here, but we've got 30 dashboards on there. We launched this platform about just over a year ago, so we already have 30 live dashboards up there and running. So those that log onto Athena can see that, and I'll talk about 2 dashboards in a second. But more importantly, we're not standing still. This is constantly being evolved. 2 things which are of interest at this moment in time is something called re-identification. So the data that we hold is about the residents, the patients of Mid and South Essex. It's pseudonymised. So when you log on, you can't actually see who the patient is. But we are bringing in re-identification, which is allowing clinicians, those that have the correct permissions, to come in, and when they're starting to look at a particular segment or a particular cohort, they can get down to the level and actually identify at a person level as well. Again, you need the correct IG cover to actually do that. So re-identification is coming in. So that's drilled down from a dashboard down to an individual, which is pretty cool. And we're accessing now other NHS tools. So we're linking those into Athena as well. So I can be sitting inside Athena and go off and fire up other applications as well. So it's this richness as a platform we're trying to expand all the time, which is quite important. We go forward a slide.
Oh, I don't know if we've lost Stephen. I think he's frozen for me. Yeah, I don't know whether we can get him back into the session. Please bear with us a minute. It was going so well.
If we just give it 1 minute to see if he rejoins. If not, Alex, we will defer to you to pick up, if that's okay.
It looks like, I don't know if he's going to see. We'll see if we can come back in. It's worth giving it a minute. Apologies, everyone.
The wonders of technology.
Yeah.
Okay, so I can't see him in the call, so I think if we can take a slight pause on Stephen for the moment, we'll come back to him kind of once we've been able to re-establish a connection. But Alex, can we maybe kind of swiftly move on to kind of the SNE area?
Yeah,
Thanks,
happy to.
If
we can move on.
Oh, Stephen, you're back. You're back.
Yeah, internet has just gone down, but I've jumped on my phone, so I can see the slides and everything else. So we can just go back. Apologies for that as well.
Thank you.
What we're going to do is we'll look at one particular area. There's 2 dashboards here. One of the things that an ICS wanted to do is really to become far more productive and get good value for money out of our investments, out of taxpayers' money. And certainly in the area of A&E is one that is constantly in the news. And on Athena, we have 2 dashboards that specifically try and drill down and find out a lot more about what is going on in A&E. We look at it through 2 lenses. The first one is looking at those that attended A&E and maybe shouldn't have been there. Maybe they should have gone to the doctor, or they've turned up and leave straight away afterwards. So again, we're doing an awful lot of analysis around those that turn up at A&E and maybe shouldn't be there. That's the first one. And the second area as well we're looking at is what are called people who attend A&E more than on a regular basis. They're known locally as more the sort of frequent flyers is the phrase that's used. But these are people who are constantly at A&E. Again, what we're trying to do is trying to find alternatives for them, different service provisions around their health as well. Again, so we're doing a lot of analysis in that particular area around A&E. So they're 2 of the dashboards that there on Athena, but equally we have dashboards in the areas of population health management, primary care, etc. Very, very rich set of dashboards there. But if I can go forward a slide, please. Athena is more than a set of dashboards. It is very much around a data pseudonymized patient database or resident database. It's a very, very rich data set. If you imagine a longitudinal record, that's what we have per residence. We have 1.2 million residents in Mid and South Essex. And this is a good example of this sort of linking together of that data from different areas. So our colleagues at Essex County Council have taken data from Athena, so health-based data from Athena, but they've linked it together with data that they hold on adult social care. It's one of the first times it's been done. Bring that data together, and what it allows you to do then is to give you insight that you previously wouldn't have had around those particular residents. So again, this is a sort of, I would say it's a first, but there are other areas where we want to be doing this a lot more. It's basically taking that sort of rich data that we have on the health aspect. Population health management is all about trying to understand improving the life of our residents, and certainly some of the biggest contributors to the health of a citizen or a resident is not actually through the medical side of things. It's actually improving education, improving employment, improving many other areas to actually help them. So by bringing those data sets together, we're hoping to actually deliver on the promise of population health management. If I come forward a slide, please. Okay, I said on an earlier slide, we have many data sources on there. Again, as at today, we have around about 600 data sources which have been ingested onto Athena on a regular basis. But message is, again, we're not standing still. We're constantly trying to find additional data sources that give us more of that insight. So again, I've listed a couple of them on the right-hand side there as well, where we're starting to look at other areas, fingertips. Some of you will be familiar with fingertips. We're looking to ingest that data. So if there is a benefit to our residents, we're looking at additional data sources to bring onto there and actually link those together. Okay, if we go forward one more slide, it's probably, okay, there's a couple more slides. I'm talking at this event, I speak at a number of events around Athena and what we've been doing here, and we're doing some press work as well, is to get the message out there. It's no more than that, so that we can work with our other ICS brethren across the UK. So we're sharing what we're doing, so we can work with other ICSs and vice versa, see how we can help each other, because there's nothing worse than people developing things in silos. And we're all trying to resolve often the same sort of problems here as well. So again, by actually communicating out to a wider audience, we're actually sharing quite a lot of information. We're sharing dashboards and insights around those as well. And events like this help us to find out what others are doing and vice versa as well. So again, we're doing quite a lot of comms work around the Athena message at the moment. I think I have one slide left. I do now. Okay, let me just finish with this particular slide. We're looking forward. We're looking at other collaborations. I talked about local collaborations with potentially other ICSs. We're looking also at national initiatives. So inside the NHS today, you may hear of something called Federated Data Platform. It's been in the press quite a lot recently. But the Federated Data Platform is trying to create at a NHS England level this more consolidated view of our patients in the UK. So again, we're closely monitoring that, and we'll join in that program. Where we think there's a benefit to our residents, we certainly will, from the Athena perspective, try and link into that Federated Data Platform. But the other area I'll mention for the moment is you'll hear something called secure data environments. You'll hear a little bit more about those. There's 4 of them in England at the moment, regional data environments. These are being built primarily for research, but the data that they're taking and will ingest will be some of the data that potentially is out of Athena as well. So again, where there is a benefit to our residents in Mid and South Essex, we're looking to join up with other programs. So again, not be siloed, not be all on our own. We're looking to join in with other programs. That's it. I'll stop there. I know we've got a Q&A session at the end, and I know there'll be a few questions along the way as well. But thanks for listening on that as well. I'm going to pass the baton. I guess it'll be across to Alex. Yes, it is, Alex. Okay.
It is brilliant. Thanks very much, Steve. So we'll take all of the questions at the end. So we'll go straight on to Alex. Thanks very much.
Thanks, Shan, and good morning, everyone. Shan, I'll try and take control of the slides so that I can move on without having to say next slide all the time. So whilst that's loading up, just introduce myself. So my name's Alex Ryan. I'm a Deputy Director for Strategic Analytics at the Suffolk and North East Essex ICS. So essentially, I lead on developing health intelligence across the ICS with a particular focus on those insights that we need in order to better enable integrated care approaches to delivering health care across the whole of the region. And I also lead on developing our kind of key strategic products, which is things like our joint forward plan, which is the Integrated Care Board's 5-year delivery plan. And part of my role is about making sure that we have the evidence base to determine our priorities. And then we also have the evidence base that articulates how we're actually doing against those priorities as well, which is really kind of key role in trying to make sure that the whole ICS is being evidence led. So let me see if I can move the slide. The answer to that is no. I don't know if someone can help me move on the slides. I'll stop control. Is anyone able to move on? Brilliant, thank you very much. Okay, so before I get into detail, kind of stepping back a little bit and thinking about the context of health intelligence and why we need it. Well, in the kind of academic world, integrated care systems have been described as a sort of wicked problem. So this impossible problem that's characterized by complexity. And these sort of complex systems have various different characteristics, which includes things like this plethora of nonlinear relationships, whereby cause and effect is never a simple relationship between two variables. It's always much more complicated than that. There's large numbers of agents within complex delivery chains, so very large numbers of healthcare providers, for instance, and very deep and broad patient pathways and complex delivery chains. And there's also this notion of kind of openness, whereby the boundaries around things are actually very hard to define. And we characterize pathways as by their specialty, or we say this is an urgent and an emergency care sector or issue, but actually trying to kind of neatly define kind of where these things start and stop is actually a very complicated and difficult thing to do. But what we try to do with healthcare analysis is try to cut through that and put in place some simple rules that enables us to manage the system, such as through the articulation of kind of strategic objectives and delivery priorities. But the World Health Organization has this model that I quite like, which is about putting people at the center of an integrated care strategy, and it's called the Integrated People-Centered Care Model. And in that, the WHO articulates how data and insights from data plays this really key role in creating this enabling environment for integrated care by enabling things like quality improvement, having high quality information systems and access to data within it, and also enabling systems research and good knowledge management, for example. And that's kind of like the context of what we're trying to achieve through, in particular, the intelligence function, which I'll mention in a minute, is about creating that enabling environment. So next slide, please. So there's this kind of notion around what do intelligent integrated care systems look like, and I think one characteristic of them is that they implement their change through iterative learning cycles. So essentially, we gather data on how services are operating, we gather information on the health of our citizens, and we then translate that data into knowledge, and we use that knowledge, that insights, to identify which services we need to make improvements to, services that we need to change or add in. And then we use data and analysis to then track kind of the impact of our service delivery through monitoring and performance analysis. And then we use evaluation to essentially close the loop back. So one of the things that we're trying to do with SNE ICS is, again, use data to try and enable this culture of continuous improvement through how we commission services, how we deliver them, and then kind of close the loop back to understanding the impact that we're having. Next slide, please. And the way that we're trying to do this through SNE ICS is through this higher ambition of population health management. So it'll be a term familiar to lots of people, but and it might mean something different to lots of people, but for me, population health management is essentially just another continuous improvement methodology, but is one that is anchored around knowledge of the population health outcomes that we want to influence, and in implementing that improvement cycle around those population health outcomes. And that's essentially what we're trying to do through our health intelligence, is make sure that we've got the right data, the right insights from that data, at all the key stages of that improvement cycle. But in order to do that, we need to have the right building blocks in place for population health management, the right infrastructure, the right intelligence, and then enabling the right interventions. And again, the analysts that we have, the data engineers, etc., we've got a really key role to play around building the infrastructure around the longitudinal link data set, having the right intelligence from that data to enable, for instance, self-service from population health insights. And then we work with kind of experts in sort of, in particular, kind of more preventative and proactive interventions, such as public health colleagues, to then make sure that we're targeting the right groups of people with the right interventions. So, next slide. So, kind of part of the context for the kind of the SNE intelligence function was the need to develop the right insights to enable these approaches. And we established this group, which is essentially a partnership of analytical teams across the ICS as a whole. And what we're trying to achieve is build the system-wide, multidisciplinary analytical collaborative that collectively produces high-quality, locally tailored intelligence from data analysis. And that essentially is about enabling kind of decision-making from evidence at all levels of the integrated care system. And the way this essentially works is that we have this intelligence function hub, which is hosted across Suffolk County Council and also the Integrated Care Board. And that hub is essentially a team of analysts that exist to deliver some very specific functions, data analytics functions that I'll cover in a minute. But then the way that we work is that we take commissions for essentially pieces of analytical research often, and where there's a common problem and a need to collectively find an answer to that, all of the analytical teams that you can see in those spokes come together to try and work together to solve that particular problem. So it's a really interesting model for trying to get everyone to collectively focus on the sort of research questions that will enable us to kind of really work on enabling integrated care and work on those sort of problems such as population health management, which would typically fall between the cracks of very specific healthcare providers. Next slide. So the intelligence function hub focuses on these core functions, and these functions are designed to try and address gaps in our kind of current analytical capabilities. So in particular, population health analytics, which is kind of built from our longitudinal data set and trying to develop insights on the health needs of the population today and in future. In particular, impact evaluation and trying to close that loop in that learning cycle that I mentioned earlier. Strategic analytics, and this is kind of where we undertake sort of 3 to 4 month long projects, which are kind of more detailed analytical research on a particular problem. So for instance, trying to really get underneath the surface of the key drivers of readmission risks across kind of acute trust would be one example, where we might spend a good 12 weeks or so doing really detailed data analysis, but also taking a multidisciplinary approach, bringing in qualitative insights from surveys, semi-structured interviews of clinicians, working with partner organizations such as the likes of HealthWatch, etc. We also have data science and advanced analytics expertise, in particular to undertake work such as mainly machine learning based risk stratification and also modeling for demand and capacity. We have an health economics function. And again, that is about trying to make the link between population health and the decisions that we're making as a system about what services we're commissioning, and trying to make sure that we're building in kind of concepts such as allocative efficiency, and are we making sure that we're kind of investing in the right services that gives the kind of taxpayer, if you like, the best value for money, whilst also maintaining the same standard in respect of quality of care. And then finally, we also kind of offer some analytical leadership around analytical professional development. Next slide. So the longitudinal data sets, sort of Steve's already described a bit about the one I'm in South Essex, and ours will be no different in that it's all centred around an individual who is registered with a GP within our geography. It's all pseudonymised data, but using a kind of common pseudonymization key, we're able to link the GP record with acute, community, mental health and social care data, and then bring in some additional information around wider determinants of health. And essentially that allows us to build up quite a rich picture of the health of an individual, non-identifiable way, what conditions they may have, their risk for developing additional conditions, and what interactions they have with the healthcare system over time. Slide. So it's structured really with kind of quite a simple model, 3 key data sets, demographic information, so key kind of information on an individual, indicators, which is essentially the kind of healthcare record for an individual, what conditions, what diagnoses they have, and then activity, which is the interactions they're having with the healthcare sector. So what organization, when did that event take place, for how long, etc. And that's enabled by having this secure data environment infrastructure and the security that exists all around that. But the way that we've tried to set this up is that essentially all of our data predominantly goes into one workspace. And then we enable analysts from across the ICS who have a reason to be looking at that data. They all have access to that data through role-based access. And that enables, that's the key kind of enabler for the intelligence function as this analytical collaborative, whereby everyone is able to work or have access to and work from the same data sets with the same tools, and we can all try and start working to the same sort of common standards. That is only, however, enabled by having quite a sophisticated information governance framework that enables data sharing to take place between all of the different organizations within the system, which is quite a complicated thing to achieve, but absolutely vital to enable this sort of collaborative working in line with the principles of integrated care. Slide. So just a couple examples then. This is a sort of screenshot from our population health management suite, which enables people to self-serve insights and do things like segmenting the population into different cohorts. So for instance, the chart on the left might be used to identify those individuals with high complex needs. So what we can see is that of our population of just under 1 million, you've got around about 50,000 people who have 5 or more long-term conditions and are classed as having high complexity needs. But those individuals, though small in number, have quite a high level of healthcare need as best proxied through the kind of cost that notionally has to the system and quite a significant price per person per year. And what we can also do in this suite as well is start to break down the drivers of healthcare need and the costs associated with that in a particular geography. And we can break that down by different conditions, whereby we can say all else equal, what the presence of this particular observation is what drives the kind of healthcare cost within that particular locality. And what we're able to do is start using this information and work with healthcare practitioners at a local level to try and identify cohorts of people, re-identify those individuals in certain circumstances, and look at where there might be a need for offering perhaps a more proactive healthcare intervention with those people as part of a multidisciplinary approach. Next slide. Population segmentation is something that we're also using increasingly. What this kind of graph shows us is how the proportion of the population within different population segments changes by age. So the categories on the right are our strategic framework, and it essentially categorizes the different healthcare interventions we have in things like be well or feel well or age well. So for instance, feel well would be the kind of the bundle of different things that are associated with managing people's mental health. And what we're now able to do is look at those kind of conditions which characterize someone's movement through different segments over time. And then we can start to use that as a framing for making strategic decisions around which interventions to start to invest in, so that we can try and maximize the likelihood of someone in a particular domain, such as well for as long as they possibly can, or try and manage the risk of someone's progression through a domain, such as going from more kind of moderate levels of frailty into more severe levels of frailty, which we know will lead to kind of more complex health requirements in future. Next slide. I think I've just got a couple more. So risk stratification, again, is another area which we're using, and it kind of links to everything that I've shared before, whereby we can start to segment risk stratify within segments. So we've got a couple of examples that we've developed locally, one around risk stratification of type 2 diabetes and another one around esophageal cancer. So with the latter example, what we've been doing is using our population health data to risk stratify individuals of their risk of developing esophageal cancer given the presence of Barrett's esophagus. And what we're able to do is work with a group of GPs who are distributing a particular diagnostic treatment called cytosponges. And we're able to look at all of the kind of the interaction between all of the different kind of features of someone's, of an individual, and interpret their risk of developing esophageal cancer. Now, risk stratification is something that's already routinely done within general practice, but through this approach with the linked data set, we're able to bring in insights from different sectors and provide slightly more nuanced kind of prediction. Huge complexity around the kind of issues that exist around health inequalities and how that can lead to biases in data sets, and the kind of ethical application of this, and really important that we're working with clinically trained people on how this is applied. Next slide. And yeah, I think it's my final slide, just to say that we publish quite a lot of reports internally around that sort of more strategic analytics work. So we've been producing some work around that's looking at the healthcare characteristics of emergency admissions and the link between those conditions, the pressures within particularly acute systems, and then how that then links back into our sort of population health management agenda. We've done a lot of work on long-term demand and capacity forecasting. We've been doing quite a lot of work again around progression of frailty, and try to identify those characteristics which are more predictive of someone's movement through different levels of frailty. And then finally, lots of work around health economics as well. So for instance, what is the value of prevention, and how do we take a value-based approach to integrated care within SNE? So that was all I was going to say. So I will pass back to you, Shan. Thank you.
That's brilliant. Thank you very much, Alex. So we'll move straight on to Carl for our last presentation, and then everyone's keeping beautifully to time. So hopefully we'll have a bit of time for pick up at one or two questions at the end. Carl, I'll hand over to you.
Excellent, thank you. I think I'm going to stick with what the others you did and just say next slide rather than try and take control. I'm also conscious that I'm going third, so I've tried very hard to try and pick something that wasn't the same, because we're all working on quite similar areas with similar data models. For those that don't know me, I'm Carl Bates. I'm the head of business intelligence for Herts and West Essex ICB ICS, and my role is very much to try and align all of the intelligence across the partnership that I work for, working with partners, working with everyone to try and get to the same outcomes, kind of similar to what we've already heard before. Everything data comes through business intelligence, always has done, and we're working very closely with our internal PHM and external partner PHM teams around population health, trying to get us to where we want to be, which is again similar to what's already been spoken, but looking at the general population of the outcomes and the health of needs that we've got, rather than isolating it in kind of silo areas. So I'm going to start with a very specific project that we've done, and then I'll move on to a kind of more kind of overarching data models, what we're doing in the future, and also give an update on the kind of data platform and the linked data systems that we're working towards getting to. Slightly behind my two kind of counterparts, but we're there nonetheless. So can I have the next slide? Thank you. So what I'm going to go through here is a kind of specific piece of work that we did for kind of North Uttlesford PCN, where we wanted to move away from the kind of individual, let's look at the kind of count the beans, the number of admissions, the number of people leaving certain areas, and really focusing on the outcomes and outputs that we could do, and affect some positive change, not just for now, but for long term as well. So we looked at a pretty common area. It's already been mentioned twice, long-term conditions and frailty, and really wanted to look at not just the admissions for falls and things like that and the attendances, but we wanted to look at a way of kind of getting a more proactive preventative care model in place to try and help this kind of area of health out longer term. So we took quite a few documents that have been done over the past kind of 2 years, the post-COVID era, looked at the kind of needs analysis that had been done, the recent PCN packs that had been released, obviously on there you can kind of see on the screen, and obviously looked at the overarching ICB clinical priorities that we've got that were obviously based off of the kind of NHS England health priorities. And as I said, the key area was frailty and long-term conditions. We looked at how we could get all of the data together into one pot. I am not as privileged as my other two at the moment to have a full linked data set yet, so we had to do this very bespokely within this area. Looked at the NHS national data sets that we've got to hand now, looked at the local data sets, and we looked at doing things differently and doing the risk stratification and population segmentation that you just heard about, using that model to really drive the kind of next phase of how we could improve the services and better still the outcomes of these patients going forward. Next slide, please. So we wanted to develop a care model for this particular cohort. There are hundreds of care models out there. This is no different to what's out there, but we wanted to really tailor it specifically to North Uttlesford and for this cohort of patients. So we grabbed as much expertise around the room as we could possibly. We really opened this up. We didn't want it to be just the health focus, just an ICB, just the old CCGs, PCNs. We wanted to really expand this out. We got kind of clinical expertise from a number of providers across not just our system but other systems as well. Looked at the kind of where people were going for their treatment and what the activities were. That was the starter. Look at what are people doing, how are they getting to the point where they're coming to the admissions, because I think for too long we've just looked side what are the emissions, let's deal with the emissions, and it was right, how are they getting there, what are the characteristics, what's happened to them over the past 3, 5, 10 years, how are they getting to this stage. So we looked at quite a big baseline data set, very much looking at, as I say, the characteristics, but also trying to diverge patterns that were coming out using models like the segmentation and kind of risk strat, assigning not really scores, but assigning a level of complexity that was happening across the system, and that enabled us to then create some outputs, which obviously then in turn fueled the outcomes as well, both the kind of medium term and long term. So we really want to make sure that we've got a model in place that's not just built for now, it's built for the next 10 years, something that we will constantly review, constantly update, and something that new staff coming into the healthcare system in those areas, be it at a trust, a community provider, wherever they're coming from, can kind of use the tools and the outputs from this to really help them design and create a service for the patients, which is inevitably what we're all here for. And not only that, to get a better quality of life for these patients, better outcomes. You can see at the end we've got the kind of overarching aim as to what we're working to, which is a quite generic kind of high level outcome. As say, we kind of came at this not just top down or bottom up, but we came at it from both sides to meet into the middle. What was the aim? Here's the input, and then how do we get there? So we were really conscious of making sure that the key outcome wasn't kind of shifted on throughout this process, that the aim stayed the aim once we'd agreed it. We'd looked at, as I say, the outcomes to make sure that they fit into there. We've got outcomes and outputs here that are measurable, some now, some over a longer period of time, but they're all measurable and all equate to getting to that final end aim outcome being achieved. Next slide, please. So this is basically a summary of the whole project. We wanted to create what we've called a blueprint, something that I know we spoke to with other ICBs and ICSs across the country, to try and firstly gain their knowledge and then to share ours. So what we've done is split it into as simplistic model as possible, so that anyone could pick this up with whatever data kind of model that they have, whatever data infrastructure, whatever IG rules are in place, pick this up, put this over the top and use this to kind of move forward and continually do it. You can probably tell I've got a bit of project management background. I'm constantly going on about reviewing stuff as and when we're doing things, and making sure that we don't just leave things to stagnate for a long period of time, that there's a constant review process. So identifying the cohort, as I said, with the population health segmentation model, you've just seen we're all doing it, all us 3 areas, every area across the country is doing it. Applying the risk strat to kind of prioritize what the cohort kind of base is for that. We've put in here neighborhood, but it could be a PCN, it could be a particular GP if you wanted to get down to that level. Quite a key thing that my colleagues I know wanted to talk about is the use of e-missing system 1 reporting. We now have data flowing in from the GP systems into our kind of linked data platform, and it's key to use these systems, help kind of work with the GPs as to what's being recorded, how can we use it, how can we analyze it, because everyone can look at data and interpret it a different way. There's no set model. There's some, but there's no set model to how you analyze these quite large cohorts of patients. So we're trying to say the blueprint is here to try and guide us through that. Review the prioritized cohort with the work area that you're working with. In this instance, it was the neighbourhood team, but with the PCM, make sure that's constantly under review. Is it still fit for purpose? What I've got a saying that I've stolen from someone whose name I won't mention, but what worked today won't work tomorrow, because the population is changing. We know this. It is a much different population now to what it was 10 years ago. The services that are there before, not all of them are currently fit for purpose, or they need adapting. So the constant review is kind of key for us. For those data literate GP people, listen to me, the SNOMED code is obviously a big thing, trying to make sure that you get that right in terms of what codes you want to link to what pathways, and make sure that they're monitored and recorded accurately going forward. So therefore, that when you get to the evaluation piece that you're inevitably do afterwards, that we will do once this program's kind of moved forward, you know, you're evaluating the same thing that's linked to the data set that you had before. So, and the last thing obviously on here is just around the proactive kind of care model, understanding the needs, delivering the work, build the plan, and the constant review, which you probably would be saying now, but going right the way through the system, continuously in improvement cycle, make sure that the evaluation brings up new ways to do things, or enhance the ways that you've got now to do it. And this is what we did with North South Uttlesford. Using the kind of fully linked data set that we were able to build, this is the plan that we were able to put in place, and this is the model that we're able to use. Next slide, please. And again, sorry, I'll put titles in there. So I'm going to spend a bit of time talking about kind of our new data platform. I was very conscious that you've seen 2 data models from Julian People, which mirrors our own. So I didn't want to put a data model up. So I'm going to talk a lot more than show it visually. So we've recently just finalised our procurement of a new data platform, which is going to take the work that the previous 3 individual CCGs did and kind of roll it into one large linked data kind of platform. So the first thing is around the infrastructure. So the key thing for us was around getting as much data, useful data in as possible into the platform. We all know we've got the standard national data sets, the SAS, the mental health, the national social care flows that they do, but we've been looking at how we can get more local flows into the system, not just with the GP data and the primary care data flowing in, but some actual local community data that from the services that not just we commission, but other providers kind of commission on our behalf, and getting their data flowed through, because it's a key part of the data of any kind of linked data set. Otherwise, we felt like there'd be too big a hole. So we've managed to get through all of the IG kind of hoops and hurdles to get that through now. So as I say, we are going live in May with this platform. On top of that, one thing that we wanted to do was make sure that we had the PHM models and tools on top of the platform for everyone to use, rather than people having to download huge 200 meg data sets and tables and email them across for people to use them themselves. So the platform will have a portal where people will be able to go on and do their own segmentation, their own kind of cohort design, cohort analytics based on all of the data that's in there. To start with, it will be kind of health colleagues first and foremost while we get the implementation finalized, but then around September time we'll be opening this up to partners such as the two councils that we work with, other ICBs that we work with, other partners that we're involved with, not just in the health sector but in the community sector away from health as well. So we've created a model where it's patient centric and it's outcome centric. So we've got a fully longitudinal linked record across the entire system. So you can see, without seeing the patient identifiables, just to clarify for any IG people that might be on the call. So it's all pseudonymized data, and you can see the client's full journey across health, across everything. And not only that, we're also able to do the re-identification that I know Stephen mentioned earlier. We have that in Herts and West Essex, and it's a huge plus for the GPs, enable us for us to be able to help them with the analytics to build the cohorts that we know that they need to kind of look towards, and then them to be able to do the last part, which is their part, to go through, identify the individuals at that level, and then carry out that kind of care that we all know that the GPs want to provide. Lastly, the outcomes framework is kind of key for us. I come from quite a big background of performance monitoring, as some of you who know me will know. We need to stop counting the beans. We need to move into outcomes. We need to actually look at the needs of the population. So this has enabled us to build a fully kind of fledged outcome framework, including with the technical specification that's being built at the moment to show how we got to these outcomes, what the metrics are, what's making up each of the individual outcomes. And I think the biggest point is that we've made outcomes and we've agreed outcomes that we can actually monitor and actually show progress on, be that good, bad or indifferent over the next 5 to 10 years. We've obviously used the basis of the NHS kind of outcomes that they have, the kind of broad outcomes that they've got, and we've really localized them specifically for Herts and West Essex and shared with them with partners before agreeing with them to make sure that it wasn't just fit for us as an ICB. That'd be too easy. We want that to go across the partnership and look at what's going to make a difference to the population of Hertfordshire and West Essex over the next 10 years. How can we do this? So we've got some pretty meaningful outcomes that are there. I can see someone's put their hand up. I don't know if they're kind of meaning to there. Apologies. I think we're coming to questions at the end, Clive, if that was Clive I just saw.
Yes, let's keep questions to the end. Yeah,
that's fine. So that's where we're at with our data platform. As I kind of mentioned, we're very keen to use a population health approach now on how we're using the data, what tools we're using, and first and foremost, just to make sure that we're looking at the whole population rather than just individual silos that was mentioned. Next slide, which I think might be my last. Oh no, I've got one more. So this is I said I wouldn't put up a data platform thing, and there it is. So this is a just kind of visual aid of how the data platform kind of works, with it being centralized, with the reporting and the scheduling and the integration, segmentation, the multiple data sources. This is how it's kind of built up here to try and look at our population. As I say, built from not just the national and local flows, but primary care data. And as it says there, free ID where appropriate is kind of key. I think I'll skip to the next slide. That's right. I think I've spoke a lot about this. So this is the last slide for me, and just something I want to bring to everyone's attention. So now that we have, or when we were finalising the contract for the linked data platform, we've also realised that there's a few kind of key elements needed to kind of upskill and improve for Herts and West Essex. So we've got into a partnership with the University of Hertfordshire over the next 2 years to look at these 3 key areas. Advanced analytics was a big one for myself and my team in BI, because for too long we've been reliant on our end for external CSUs, other providers, to come in and help us kind of build stuff from the start, and then we have to try and pick it up and move on. And with the high turnover of staff that we have in the NHS, that doesn't quite work. So we're bringing that in-house. We're making sure that the staff are kind of skilled up to be able to deliver demand and capacity models themselves and build a model up from scratch and keep that model, and more importantly, build a model that we can tweak and that we can change over time as and when it's required. The scenario modeling that's already been spoke about, the segmentation, the risk stratification kind of model, all of that using tools. Alex mentioned them earlier, R, Python, tools that are quite new to us in the NHS world, but have been around for quite a while. Getting up to speed with getting the workforce and getting the analytics done right there on that. So speaking of workforce, I would like to start by saying I have a fully fledged, highly skilled set of analysts within my BI team, but they're very eager to learn. And what we have agreed with the partnership is that not only will we be upskilling and creating kind of courses for Herts and West Essex, but we want to be able to share those courses with everyone across the health platform, and not just in health. I know Essex County Council has been involved in conversations initially about this, and we want to make sure, and I'm going to steal, I think, what Stephen said earlier, we want to make sure that everyone's using the same kind of tools and techniques that's available to them, rather than someone going off and doing their own kind of piece of work. So it's quite a key thing for us is to share the expertise that comes out of this and share what we're able to build and provide across the platform and across with this University of Hertfordshire, the University of Hertfordshire partnership with everyone, so that everyone can take advantage of that as well. Lastly, just around predictive kind of models, something that we've obviously done, as you can see, in North Hertford, and we've done quite bespoke pieces of work. We want to build a more cohesive and kind of co-designed, real predictive demand and capacity and planning kind of model going forward. Those of us in health will know that we have the dreaded kind of operational planning rounds that come around every year, and for years they seem to hit us like a ton of bricks. So we're trying to get ahead of that and trying to move into a position where, when the operational planning model is around, we've got models set up already, not just based on previous years, but based on a kind of future predictive modelling, looking at how our cohorts and our populations are going to change, how the outcomes might change, how the segments could change depending on this, etc. Trying to link everything together, and all of this is possible with the linked data set that we now have. Linking, as I say, the data from start to finish, right the way through, is able to kind of share with us and show us what would happen. I'm also going to get told if I don't mention that we're going to be building a do nothing model as well, which I think is quite key to kind of show what the impact would be of doing nothing. Sometimes it's good, sometimes it's bad, mostly the latter, but I think that's key for the kind of care settings that we're looking at, particularly the cohorts, the 5 main ones that we're all talking about: frailty, long-term conditions, diabetes, all of the kind of key areas that we look at. The do nothing kind of model shows how it would change drastically the kind of demographics and complexity of patients going forward, and how different things would be in 10 years, 20 years time if we don't do stuff now. So that was just a whistle-stop tour of kind of 3 kind of key areas that we're kind of working on in Herts and West Essex. I do very much generally believe that this is quite an exciting time in health analytics at the moment, with advances in AI and the tooling and software and systems that are out there now. Things are being able to do. I'm pretty sure 5 years ago, myself, Alex, Stephen wouldn't have thought we'd have a fully fledged linked data platform across our areas. So it's moving at quite a pace, and it's quite a joy to be a part of it. So I do appreciate everyone listening. Thank you very much.
That's brilliant. Thank you so much for all of our speakers. 3 fantastic presentations. Yes, rounds of applause all round. And absolutely, it just shows how much is happening so quickly. And the other thing that struck me just listening to the presentations, all of you described how sort of patients and residents at the heart of everything, and building that, working with clinicians to drive that culture of continuous improvement. So really good to see that. We do have a little bit of time for questions, and thank you for keeping beautifully for time. We've got some questions in the chat which I do want to go to, but we've got one hand up, so we'll take the one hand and then we'll go to the questions in the chat. So Clive, did you, oh actually, can Clive, I'm not sure if you can come off mute, Clive, so you might have to put your question, or you can. Well done.
Yeah, I'm really sorry. I didn't mean to interrupt you, Carl. I was just a bit eager to get in to speak. Thank you all 3. Really fascinating, really relevant, and makes so much sense to us. I represent the CVS in Uttlesford, Chief Exec for UCAN, and we've been working with our PCNs and very much involved in population health management, and recognise the extreme benefits of data sharing and exchange and analysis. The challenge I'm coming up against all the time is the voluntary sector as the poor relation in this relationship. Whilst the ICB are very keen that we're equal partners in this journey with you all, as far as data is concerned and access to data, we're not getting it. And we've got so much data to share with you from our own perspective and are willing to do that. But also, you know, amalgamating our data and analysing our data would really benefit, I think, us mutually. And we are trying to, as an organisation, acquire the data security tool, the NHS data security tool, which is no mean feat, as I'm sure you all know, and the Cyber Essentials Plus qualification or accreditation, to convince partners that, you know, we're an organisation that can be trusted and understands the sensitivity of managing such data and handling it in the correct way. Have any of you overcome that with your voluntary sectors? Because I think without them, moving forward at the pace you are, certainly in North and Mid Essex, and I'm sure West Essex and Herts will follow suit rapidly, leaving the voluntary sector behind would really, I think, have massive impacts.
Thank you. Great question. I don't know who wants to come back in on that. Carl, go for it, and then Alex.
I'll come back in. So I can take your question in 2 parts, Clive. So the last part you said about how we've tackled it. So I can't talk for the others. I'm sure they'll kind of step in. We've kind of tackled it really bespokely up until now, in terms of we've identified maybe a piece of work, and we've worked with all the providers, including voluntary sector, in that specific area for that specific cohort or service level that we were looking at. So we haven't done anything kind of overarching across the whole kind of population as yet. I can talk for our platform. The voluntary sector is very much a key sector that we want to get involved, not only in the data sharing from them to us, but from us to you as well. So we do have the voluntary sector and all of the kind of providers on our list for kind of later down the line. We're obviously not there yet, as I say, we're literally in the implementation phase of our kind of data platform as we speak now. So I don't even have a linked data record for the whole of the partnership yet up until May when it goes live. But very much by the end of the year, we'll be looking at how we can do that. I'll have to speak to you maybe offline about how you can get the kind of accreditations and stuff like that, and what you need to do to do offers, as I'm sure you're already aware of, Clive. But yeah, I'm happy to have conversations kind of separately if that helps. But yeah, the voluntary sector is there. I don't think there is, and Steve and Alex will correct me if I don't think there is a way just to get things through. I think that's part of the problem with data. There isn't just a one size fits all, because otherwise we'd all be doing it and we wouldn't be here talking on about linked data and how we've now got kind of systems. And so we are very much kind of leading this as we go through it, particularly around the IG. I know the IG can be quite tricky. it's a swear word to most analysts, IG, so it can be quite hard to get around, but I'm sure we can find a way to do that.
Thanks, Carl. And Alex, did you want to come in?
Yeah, so I agree with everything that Clive said, and Carl's right. There is a way. It's just there's not necessarily a standardized way that we're all doing across the NHS. It feels as though every system is having to try and figure this out for themselves. The way that we've done it is essentially it's about kind of having different layers to your data and your insights, whereby at that kind of person level data, the most sensitive data, you've got that really strictly controlled within your secure data environment, and only data professionals, qualified people to be using tools to analyze that data can access it. But for our population health management reporting suite, the bulk of that is quite high level aggregated statistics with small number suppression and things like that. And that information can be shared quite widely. And we share that with our VCFSE within our integrated care partnership. So people can have access to that. As long as they meet certain criteria around things like having done the data protection and security toolkit. And then we just ask people to sign essentially a small memorandum of understanding that articulates the use of the data and kind of what they're allowed to do with that. But that's quite light touch. And then the other thing that we do is our intelligence function takes commissions from all organisations within the ICP, not just NHS or county councils. And we've recently completed a piece of research for St Helena Hospice, for instance, who are going to outsource that and potentially pay a lot of money to consultancy, and instead just asked us to do it. And I like to think we did just as good a job, but no, and we got good feedback. So I think there are ways that we can support. And we do need kind of, there's a really good quid pro quo there.
Thank you. Stephen, did you want to come in as well?
Nothing more to add than what the guys have already said there. It's very, very similar. It's early days. As I was sitting here, I'm trying to think of a good use case that we've had so far. We haven't had one so far. So I think I'd want to see a good use case why we want to be doing this. Yeah, again, getting the IG correct is absolutely key on this as well, and getting the standard, because we're interchanging data here, so we've got to have a set standard that allows us to ingest it so that we can actually get something meaningful out of it. But I'd love to see a good use case where we can actually move this forward, because this clearly is a gap for us, I know, at this moment in time.
Thank you. I think we've got probably one time for, I was going to say one question, but I think we can combine the question that went into the Q&A right at the start with the one that's just gone in. So there was a question about referencing, there was a specific question about food bank data, but perhaps we could sort of think about sort of data on those wider determinants of health. And then there's also a question about sort of thinking about how useful the models can be in terms of trying to scale up prevention work, sort of tackling things such as diet, nutrition, quality of housing. So there's potential to sort of address both of those. So I suppose it's a question about thinking about those wider determinants of health and the opportunities around there. So I don't know if anyone wants to come in on those questions.
Yeah, if I go first on that, I think that's clearly we built, all three of us have built a foundational sort of resident view, whether we call it a longitudinal view or whatever we want to call it. So we've all pretty much built those now. It's now starting to add those additional data sources on. So when I spoke about adult social care with ECC as well, that's starting to bring those together to see those insights. But we need to then start to build up from that. Certainly housing data is something that I think is going to be very, very useful to add to our own record set, because that is quite key. And then education data onto that as well. So we've got the foundations in. We haven't got to that next stage, but clearly that's really where we want to go from here.
That's great. Thank you, Stephen. Alex, do you want to come in?
Yeah, so just say we work quite closely in Suffolk, which is slightly outside this geography, on the Suffolk Office for Data and Analytics, and who are based in Suffolk County Council and hold data across the wider sort of public sector services within their geography. And they've been doing some work to look at linking housing data to healthcare data, and they found that they got a sort of 80% match on NHS numbers with housing data, which would enable us to start linking into our data. The issue we've got with all of this is that you need really, really good use cases in order to make the case to be linking this wider data on wider determinants of health to NHS data. And a lot of this is decisions that get made at a national level with some information governance guidance that is not really been keeping pace with how we want to deliver integrated care in 2024 and beyond. So I think we're probably all collectively at the point now where we've got those foundations in terms of our data and the use cases that are being enabled by that, but we're probably now pushing boundaries in terms of what the wider rules are around what we can do with our data. And a lot of this needs to be resolved kind of nationally as part of the wider agenda around enabling data for kind of population health management.
Brilliant, thank you, Carl. I don't know if you want to also comment on that question.
No, I think they're both probably covered it. I would also touch on the fact that what Alex just put there, it is a kind of national drive that we need on some of these, because there is only so much that we can actually do locally before we hit one of the walls, which is normally you can't share the data, or you haven't gained consent, or whatever it is around the IG is always the kind of blocking barriers that all of us here would love to get. Particularly the education and house data, as Stephen said, that would be fantastic. The work we could do off that would be phenomenal, and not just in the health sector as well. I haven't worked in local government before. I know the benefits that the health data would provide the local government for a lot of their kind of work that they do and their outcomes that they want to achieve. We do just always seem to come back to this horrible block of hitting IG rules where we can't get kind of data shared for one reason or the other. It's been a lot better since COVID happened. I think that was a big eye opener. I think the way we were able to share data kind of helped. We'll get there. I think we'll get there as fast as we can, I think is the simple way of putting it.
Thank you. I'm conscious that we're almost at 12 o'clock. So Harriet, is it a quick question? Oh, Harriet, are you there?
Thank you. I wasn't sure if I could re-enable my mic. Very quick questions. I know we're out of time. It was just to say that it's something we're very much looking at with data transformation and data sharing with regards to supporting families programme, which you might not be aware of, but it's a children and families programme. We work to the government, it's Department of Levelling Up Housing and Communities, and it's moving over to DfE, but they're very much pushing us to do data sharing and looking at how we can support families and children with multi-agency shared data and how we can work in that way. And one of the challenges we've had is like you said, it's the kind of IG around really what are we doing with that data, because we need to justify to hold it, we need to be actively using it, and we're constantly though looking at how we can use our children and families data, that sort of children that get referred in for extra help and the stats around why they're being referred in, a bit like your A&E. Our children and families front door gives us quite a lot of insight as to what's going on a family level with DA, and they might be presenting to us with parental conflict or trying to think of an example, financial problems, etc. But that information and data, I think, could be quite powerful to you guys to look at an all-age approach. So I am here. I sent an email to Stephen at the beginning of the chat, but I'm sure you guys can kind of work amongst yourselves. But yeah, just as if there was something we could do to support our programme, but also support your work with another data feed around children and families to look at an all-age approach potentially.
That's brilliant. I'm going to call it a halt there, but that's really nice because I know that the overarching theme of today is collaboration. So that's a really nice point to end on. I'm sorry that we didn't get to all of the questions in the chat, but please, if you could join with me in just thanking all of our speakers. I think really fantastic presentations all round, and also a sort of really important theme about sort of making sure that we use the data appropriately and safely, with all good governance. The recording will be made available through the portal at the end of the conference. But thank you again, everyone, for your questions. But particularly thank you to the speakers. It's been a really fantastic presentation, and I'm going to close it there. Thank you all, everyone.